A patient can survive hypertension for years, but hypotension, sometimes minutes, decide everything. Today, we talk about hypotension and shock. And before we go further, let me ask you a simple question. Do you know what sympathomimetics really do in shock? Not the names, not the lists, but the reason we use them. Let's begin calmly. What is shock? Shock is not just low blood pressure. Shock is a medical emergency. It carries a high mortality, even with treatment. The common causes are easy to remember: hemorrhage, sepsis, myocardial insufficiency, different causes, one result: inadequate tissue perfusion. General principles of management. Always remember this rule. Treat the cause first, not later. First, because profound hypotension must be corrected urgently. Delay leads to predictable consequences. Tissue hypoxia, then organ failure. Once organs fail, recovery becomes difficult. Volume replacement, the foundation. In many types of shock, the problem is simple. Not enough circulating volume, so fluids come first. Volume replacement is essential in hemorrhagic shock, septic shock. It corrects hypovolemia, it restores preload, it improves perfusion. But pause here. Fluids are not always harmless. In cardiogenic shock, excess fluid can worsen pulmonary edema and overload a failing heart. So never give fluids blindly. Always think. Now, sympathomimetics, sex. This is where many students get confused. So let me ask again. Do you know why we choose different sympathomimetics in different shocks? Because the heart, the vessels, and the volume are not failing in the same way. Inotropic sympathomimetics. These drugs are used to improve cardiac output, but only when the hemodynamic status demands it. Common inotropic agents you must remember: adrenaline, also called epinephrine, dobutamine, dopamine hydrochloride. Each has a role, each has risks. Septic shock, a classic exam scenario. Management starts in a clear order. First, fluid replacement. Restore volume. Second, inotropic support. If blood pressure remains low despite this, then and only then, use noradrenaline. Noradrenaline acts mainly as a vasoconstrictor. It restores vascular tone. It supports perfusion pressure. This is first line in septic shock. Cardiogenic shock, important warning. This is where exams trap students. In cardiogenic shock, peripheral resistance is often already high. So what happens if you add more vasoconstriction? You increase afterload, you worsen myocardial performance, you reduce tissue perfusion. Result, more ischemia, worse outcomes. So be very careful with vasoconstrictors here. Safety and monitoring. One point BNF is very strict about: sympathomimetic inotropes and vasoconstrictors are not ward drugs. They should be used only in intensive care settings. They require invasive hemodynamic monitoring, because these drugs save lives, but they can also end them. A special situation: anaphylactic shock. Anaphylaxis is different. It is rapid, it is severe, it is life-threatening. Management follows specific guidance under antihistamines, allergen immunotherapy, allergic emergencies, and remember, adrenaline is the key drug here. Vasoconstrictor sympathomimetics. These drugs act mainly on alpha-adrenergic receptors. They cause peripheral vasoconstriction. They produce a transient rise in blood pressure. They are used as emergency measures when other treatments fail, but never forget the major risk. Blood pressure may rise, but perfusion to vital organs may fall, especially the kidneys. High pressure does not always mean good perfusion. Hypotension due to spinal or epidural anesthesia. This is a very practical situation. The cause is simple: sympathetic block. Management includes intravenous fluids, often prophylactic, oxygen, elevation of the legs, pressor drug administration, ephedrine hydrochloride. This is a commonly used pressor drug. Why? Because it has dual action: alpha effect, peripheral vasoconstriction; beta effect increases heart rate. So it is especially useful when hypotension is associated with bradycardia. Persistent bradycardia. If bradycardia continues despite correction of blood pressure, use atropine sulfate intravenously. Simple, direct, exam-friendly. Shock is not about memorizing drugs. It is about understanding physiology. Volume, pump, vessels. Fix them in the correct order. If this made sense, pause the video. Write the flow once. This is how concepts stick for exams and for real patients. If you're serious about mastering BNF, support the channel, like the video, share it with one friend who is struggling. Subscribe so you don't miss what actually matters. In the next video, we move one step earlier: cardiovascular risk assessment and prevention. Because the best treatment for shock is preventing the disease that leads to it. Stay with me.